at 2 o'clock. Actually, it's a little after, but and I'm going to take the roll call. Mary Ann Abadi, present. Richard Kunert.
Present.
Dr. Edward Copeland.
Present.
Danielle Angeliri. Dr. Bill Gorski. He will not be with us today. Dr. Terry Giardini.
Here.
Dr. Julie Morris.
Here.
Kim Neighbors.
Here.
Linda Sandquist.
Here.
And our advisory members, Wendy Larson Bennett. And
Here.
Jay. Thank you. Jay Ware.
I'm here.
Okay. Did we have any requests for public comment? Not that I was made aware of.
No, we did not receive any. And while we're on that note, I will say I did follow up with the chairman's office to ensure that they were giving us any comments that they received. And they are aware of that procedure, but have not received any for any of the meetings. So that's why we have not received any. And moving forward, they have asked that we change that contact from their office to potentially, I guess, Region 1, or if one of the board members wants to receive those requests, that would be fine. But they have asked that we change that.
Okay. And Jason, I'm going to back up for just a second. I didn't call your presence. Jason Holcomb, our board leader. And then Dave Kralinkas, I see that you have joined us from the state's attorney's office. So I just wanted to make his presence known as well. And we have a R1 visitor with Jason, and you might want to introduce her just so the board knows.
Kristen, you want to introduce yourself?
I'm Kristen Hayden. I'm a new Greenest Region Corps member working with Region 1 planning through Americorps.
Welcome. Okay, moving on. People are just acknowledging, okay. The meeting minutes that we have to approve today are actually 3 sets of minutes. The first one being September 2nd. And I'll need a motion for approval.
So move.
Do I have a second?
Second.
Second. Did you, Danielle, did you see who made the motion in the second? Okay. All those in favor, please say aye.
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 Any opposed, same sign? The minutes for September 2nd were approved as presented. We need a motion for minutes from the meeting of, September 11th, 2020. I need a motion for approval.
So move.
Dick Cooner is moved. Second. Second, Dr. Morris as second. All those in favor say aye.
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 Any opposed, same sign. The meetings for September 11th were approved. And there was one other date here, right, Jason? Because you put
September 23rd.
and September 23rd, yes. I'll need a motion for approval.
So moved.
Dick Cooner, second.
Second.
Dr. Morris, second. All those in favor say aye.
Aye.
Opposed, same sign. The meetings from September, you said 23rd, were approved as presented. Okay, we have accomplished the 3 sets of minutes. Now we'll move on to the communications calendar. And this is an action item. And Jason, do you want to take
We'll do a
this?
share screen for this, yeah.
Pardon me?
We're gonna share our screen.
Perfect.
It's that edge, yeah. And then I'll scroll down. All the little bit more of those are all meeting minutes. We're just scrolling through the meeting packet here, so we'll keep going. Those are meeting minutes. And just a little bit further, it'll look like a calendar when you get to it. There we go. Okay. Can everybody see the calendar?
Yes.
Okay, so just to provide some brief context on this, the communications champions have been working alongside with me, and we have an intern from MSW, Masters in Social Work intern from Erickson Institute, who has done some extensive research on this to put together a best practice communications plan. So part of that was a framework that's probably about 10 pages thick of identifying target populations, different populations to whom we would communicate, and what some of our target messaging might look like. So that would include differentiating, let's say, public officials from general voters, from people with lived experience to family members of people who have mental illness or addictions. And so that was kind of some of the background thought and research that went into identifying why we would use particular communications channels and what type of goal we have with each of this communication action items. So you are welcome to see all that. I'm trying not to bombard everyone with, 100 pages of information every week. So if you would like to see the entire framework, please let me know and I will email it to you. But ultimately that has culminated in this calendar, and we did a 6-month calendar rather than a 12-month, since the communications, I think there'll be a little bit more of a learning curve with it, and we'll have to assess a little bit more frequently how it's working. So we've put together a 6-month platform, and we can certainly evaluate that in 6 months, or we may even determine that we need to reevaluate it sooner than that and make some modifications. But starting in October, that's actually Mental Health Awareness Week, as Danielle, I'm sure, is well aware. She's been busy doing things with Nami for that. We have our meeting today. As a matter of process or procedure, we're recommending that for every board meeting moving forward, we have a press release that is prepared and ready to be released after the board meeting, so that we are being more proactive with our communications and less reactive, and putting the message out for the news channels and such, so that we're not just sitting back and waiting for people to give us phone calls at the last minute asking for interviews. We're recommending that we have a Facebook page because of, especially during COVID times, that's probably one of the best ways to engage community and offer some level of public participation. I think one of the potential risks associated with Facebook page are the type of what's commonly called trolling in the social media world, where people can kind of go on and bombard you with irrelevant comments. So on Facebook, you cannot disable comments, but you can remove inappropriate comments after they've been posted. So that would be something that we would have to manage. We do not anticipate there being a lot of Facebook posts, but what we could use that for is posting when we have meetings. It would be another way to engage a larger portion of the general public about the meeting and what the meeting is going to cover. Also, we've discussed the idea and are recommending that, since we will already have a YouTube channel in which we will be live casting our YouTube meetings, that once a month we do a short video that gives an update from a board member, potentially the president of the board or another board member when appropriate, and that prior to that, a week in advance, we would post on Facebook an opportunity for public to submit questions to the mental health board that would be screened ahead of the recording of that video, and we would answer a select number of appropriate questions so that we can give the public an update on things that they might have specific questions about. Those videos could be pre-recorded, not necessarily need to be live, so it gives us the opportunity to edit or stop and re-record if we need to, so it doesn't have the same, I guess, risk associated with maybe doing a live video. We also, in our budget, put in for the ability to have a content management, email management platform such as Constant Contact or something like that, that would allow us to do email updates to specific stakeholder groups. So for example, we already have a stakeholder list of the agencies who filled out our environmental scans. So on a monthly basis, we could send an email out that's just targets that group and gives them an update. And we may develop other types of stakeholder groups as we move forward that we want a more specific update to. Okay, let's go to the next month on the calendar. So some of this will be a little bit repetitive because we'll try to have some consistency. So you'll see a lot of the same things in November that you see in October, and it's just kind of repeating each month to create kind of a more predictable communication platform where people know what to expect and how to engage. One thing that was recommended, and Terry, I'm going to let you maybe talk a little bit about this because you did a lot of the background kind of homework and vetting of this, was the idea of being proactive to get our faces and names out there, and who are the board members, who are the Winnebago County board members, and what's kind of a creative and fun way we could really introduce everyone to the public. And Terry came up with an idea for some public service announcements that could coincide with the holiday season. Terry, do you want to briefly speak to that?
All right, everybody indulge me. All right, so here's what I was thinking. And Tim, I want to give Tim some credit on this too. Tim and Jason and I met last week, and we got to talking about some different things. Now, I'm going to appeal to those of you who remember 1976. Hey. Raise your hand. Thank you very much. I was there. If you remember, there was, Dick, I'm glad you were there too. If you remember, there used to be, they did that bicentennial minute. You remember that?
Yeah.
And they were commemorating the bicentennial. All right. So the three of us were talking last week and thought we'd come up with some PSAs. Now, the station I contacted, would be 23, said that they are not able to do any PSA work up until right now because the election's going on. After the election, different story. So what we had come up with is that we would do like a mental health moment, 80 words or less, roughly 30 seconds. So Mary Ann, you would go first, and you would say, "Is hi, the holiday season is upon us, and what comes up first? Besides, it's tradition, family, get-togethers, happiness, and what about loneliness?" And you can talk about anything you want to talk about. And you would do it 80 words or less. And then you would say, and I am Mary Ann Abadi, president of the Winnebago County Mental Health Board, and that's your mental health moment. Or making 815 mentally fit. I was told to come up with a branding statement. Now, that doesn't have to be mine. I mean, if you could think of something better than making 815 mentally fit. They don't want to say Rockford. They told me to stay away from that. If you're going to do the community, incorporate everybody. Because if you just keep it to Rockford, then Loves Park feels like they've been left out and what have you. You know what I'm getting at, right? Mm-hmm. So they would run about 2 or 3 times a week, maybe more, depending on what is all going on. I'm looking at starting this, like, is this the month of November you have up here? Yeah. We start like the 16th. So the election is over with on the 3rd, 4th, whatever all the mail-ins come in. And then we can start recording them on the 9th. So, Mary Ann, obviously, I think you should go first, followed by Dick, followed by, Reverend Copeland, followed by Danielle, and right on down the line. And everybody pick something that you think is important to talk about in 80 words or less. And again, you end with your name and the Winnebago County Mental Health Board. And if we want to go with the branding statement, they recommended that. Okay? I mean, that's it in a nutshell. Mary Ann, one other thing too, I think this is important to note. Channel 23 has started a newscast at 4 o'clock, and they need more content. So talking to someone like yourself to talk about that as an interview for that television programming time would be good. They also said if we went with a on-air talent, that we would be limited to only Channel 23. If we did it generically, where, again, Mary Ann, and everybody else on down the line was to do one, then that way they can maybe air on all 3 stations. All right, that's it.
All right.
I just want to comment that I think we should be careful that we not exclude any of the local stations. So maybe reach out to all of them to help us with this.
Hence, when you do a generic one, that's how all 3 stations will pick it up. If you do an on-air talent, then it only stays with 1 station.
Right.
So they suggested if we wanted to do that.
So the idea would be that we could record the videos in Zoom, and then we could have both an audio and an audio video file, so we could submit them to multiple stations and radio stations, and then they'd have multiple files that they could use and kind of play them multiple times per week and have them mix them up a little bit, so it's not just the same person over and over again.
I think it's a great idea.
Before we move forward, is there any discussion or thoughts about that particular?
Yeah, I have a quick question, if I may.
Please.
Sure.
So, first of all, I love the idea. I'm wondering what has been the discussion as relates to generational outreach. Facebook and YouTube are great. I'm on, as a pastor, as an old man, as you can see, I'm on Instagram and Twitter, not because I particularly care for either one of them, but there's a generational divide as it relates to my membership's preferred way of receiving content. And so I do, as an example of what you're just talking about, I do like a 2-minute devotional, just started doing it every day for the last 2 weeks, that I post on Facebook, I put it on YouTube page, put it on our Instagram, as well as Twitter, to the extent I can, because those are completely different communities, really. And I'm wondering, again, since it's not extra work for anybody based on what you just said, I mean, you video one thing and you can put it on multiple platforms. I'm wondering, has there been discussion? I'm not suggesting that Instagram or Twitter is the only way, but I'm more concerned about reaching out to the younger segment of our community, as opposed to people who look like or who think like me. Let me get on the Facebook and see what's going on here. I mean, I think there's an opportunity, even perhaps with the school district, some kind of way, school districts, pardon me, some kind of way to really interact with, if mental health fitness is one of our goals. It seems to me that maybe there's some discussion that needs to be had regarding the younger generations.
I'm sure, I think that's a great suggestion, and I don't see why we couldn't put on more than just one. Absolutely.
Yeah, we did research. Twitter in particular was mentioned as a platform to reach the younger generation in our communications, I guess, framework, that especially some of the research that Lauren did here, the intern that was working on it. So why we didn't put on the calendar, I think, was just not wanting to bite off more than we could chew. But I think your point is well taken, that it really wouldn't probably be a lot of extra work since we already have the content. We just really need to put it on a different medium.
And in that vein, for the old people in the world, you know, we might reach out to the RR Star or Rock River Times or some of the small town newspapers, so we could convert the video into a written, you know, mental health moment, or making 815 mentally fit, because they're always desperate for content, local content. Maybe not the RR Star so much as some of the satellite papers, but that would be easy to do. And I think we could work on that as a committee.
As for the social media, there are like platforms where you just have to post one time and it goes to all of them. I just would have to look up what it's called because I don't remember.
Hootsuite is the sort of gold standard, but there might be better ones now. I think that's a great point. And also, as it relates to what Wendy was just saying, we use a app too that's free called otter.ai that transcribes your stuff for you. It's not like somebody got to go back and write something. I mean, while you're doing it, you can just transcribe it right there. And it's super proficient. And it's, at least I think, first 600 minutes a month are free, something like that, which is
that's awesome.
More than enough.
And, you know, the other thing we might want to think about is doing a Spanish language translation. And, you know, some of the folks we worked with during the referendum might be some people we could tap into to help us get this into Spanish language media as well. So I think the concept is excellent, and we can work on polishing
and expanding.
Yeah. And Danielle, also, I'd love to see us hooking into the NAMI sort of universe as well.
Definitely.
You know, so whether it's your pages or whatever, you know, so that we're reaching a broad community.
Yeah. So if we scroll down, let's scroll down the next month. We do have the Nami Newsletter. As I understand, it comes out quarterly. Is that correct, Danielle?
Mm-hmm.
I had a comment to follow up Wendy's. I think if we're going to look into getting it translated into Spanish, we need to see what other languages it needs to be translated into. I think that we overlook the diversity of this community, especially now that there is a growing Arabic community, and we don't want to just focus on English and Spanish.
Yeah, and also there's a pretty significant Southeast Asian population. So, okay, that can be sort of the research piece of how do we broaden this?
Yeah.
But then that means we have to have services available, and that's the real challenge.
Well, that's part of
yes, that's
what
part
the
of
environmental scan is going to
right.
point out to us today, the need for interpreters and whatever. So
Yeah.
anyhow.
So also for December, if you'll note, that's pretty similar. There will need to be for a annual report that will be issued in December per our bylaws in the Community Mental Health Act. So that's something that also needs to be developed and released. I put released on the 3rd only because looking at our board meeting schedule, we'll actually have to draft that in November so that we can review it for approval at the December meeting. So we can release it maybe as early as the 3rd and as late as the 31st. You can continue to scroll. So the rest of those are just repeat things of kind of doing a monthly YouTube video, a couple Facebook posts. In January, I think we'll want to think about doing a virtual press conference that will coincide with the release of our 3-year strategic plan and the RFPs that will be going out. That will probably be the end of the PSA campaign as the holiday season will be over. Okay, scroll down to February. There's really nothing unique about February. It's just a repeat of kind of those same items, and the same thing with March. And then we could reevaluate at that point and build another 6-month kind of view of see what's working, what gaps we have, and what maybe additional platforms. But I'm already noting that I'm hearing feedback that we might want to already consider adding Twitter and Instagram.
Right.
My other comment would be thinking about whether you want the members of the mental health board to be retweeting, liking, sharing things on those social media platforms, because that's the only way really to build a following. So I think that needs to be part of this, and not necessarily, I mean, I think we just need, I'm not suggesting that we have policies, but we probably need to think through about how we want to do that so that none of us are posting random things that shouldn't be posted, or our own opinions, and it looks like it's part of the mental health board. So I fully endorse this and think it's a great idea and support it being on multiple channels. I think we just need to think through what that's going to look like.
And the other thing is topics. I hope we can draw on our own pool of expertise. We have some pretty amazing people with diverse areas of expertise. So when we're talking about topics for the holidays, I hope you'll speak up and share those.
Jason, you need a motion to have this plan accepted. I know that. My question is, if we approve this plan, we are not, we're not disallowing the possibility of adding to this before the 6-month ends, correct?
I don't see any reason why we would be, yeah, I think we could amend it as we need to.
Okay. That's what I wanted to make sure of, because even this discussion, there's some changes and tweaking that we need to do, and a kind of more detail along with the plan in terms of how we're going to ensure what Linda was talking about in terms of, opinions, leaving. Once we introduce ourselves and we become more familiar with the public, it's more important that we stick to our messaging, from the board perspective about mental health issues. So, okay. So, any more discussion? If hearing none,
Oh, go ahead.
go ahead. If there's none.
I was just going to say the other thing that we discussed, and this is kind of parallel to this, it's not necessarily tied to the calendar, but speaking to Linda, your concern, and Marianne, you're kind of following up on that we also have a media request, I guess, procedure or process through which media requests could go to me, let's say, and I'd have some questions to screen those requests, and then connect that the request with the appropriate person based on the screening, or in some cases let them know that that would not be something the mental health board is interested in based on the screening questions, which could include, for example, are there any other organizations being interviewed in this particular piece you're doing? When will it air? What is the purpose of the piece? What are the questions you're going to be asking?
Jason, I have one that United Way uses for media relations that directs everything to our director of communications. I can send that to you so you can at least, look at it as a template then.
Please, that would be very helpful.
Okay, I will send that to you.
Okay, any other discussion? Hearing none, could I ask for a motion to accept the communication plan as presented?
So moved. Some neighbors.
Tim, thank you. I need a second.
Second.
Dick Kunert, second. All those in favor of accepting the communications plan as presented, say aye.
Aye.
Aye. Any opposed, same sign. The communications plan has been accepted as presented. Thank you very much for the communication champions. I think this is a great start, and you know, it's really going to be able to just allow the community to hear more frequently from the mental health board, and I think that's really important. We really are striving for that transparency, and this is going to launch that. So thank you all, and Jason, thank you as well. Moving on to the next agenda item is the service agreement, and that agreement is between the Mental Health Board and R1. And as you know, we had the initial 90-day service agreement, and Jason's bringing it forward. He certainly has updated all of the necessary areas that, you know, we need to move forward. And Ed, you and I would also, it would be required that we, myself as the president and you as the treasurer, would sign this agreement. And nothing really in the agreement has changed. I mean, there's the only difference is that it's really going to be extended. I should stop there though. Jason, are there any details that did change in the agreement?
Yes, highlighted in yellow are the changes. So the first change is just the date, obviously.
Yes.
Okay, I changed the scope to fit more strictly the work plan that was approved.
Okay.
I know that the first service agreement was a little bit more vague just because we were still kind of figuring out what the functions were. So this is, as you see, planning, request for proposal process, evaluation, communications, and coordination, kind of the 5 areas that we've all defined as being part of the process, and then with bullet points that are specific to those kind of actions that are part of the work plan that was approved. So it's all keeps it very aligned with the functions being aligned with the work plan.
Mm-hmm.
And then the completion date, of course, I'm putting that for 1 year based on the work plan being for 1 year. I assume that was the period of time that we were discussing. I would also, I have added an option for paid intern support. We certainly have a number of professional staff that can be utilized at the member rate of $85 an hour. We do have, in addition to Kristen here, who's an Americorps member, we have another opportunity to bring on a public health specific Americorps member. This would be a master's degree student, someone who's completed a master's degree in kinesiology with a background with a specialty in behavioral health, and basically taking what our real cost would be on that and dividing it by the amount of hours. It would come around $12 an hour for that rate. So it would just be kind of same idea, build at an hourly rate, but the rate will be significantly lower than the professional services rate. And I think there would be a lot of potential value in that, especially as we add on some of these additional components like doing communications and trying to keep up with the frequency of what's needed for that. It might be helpful to have someone who has a lot of availability at a lower cost to help supplement some of those functions. So,
And comment on the fact that it does not increase what we have budgeted to pay R1.
Exactly. I would proactively manage those hours to make sure that nothing's exceeding the rate of the total approved amount, the maximum amount of $13,600 per month. If for any reason we ever did exceed those hours, there'd be no billing to the mental health board for that. That would be on us. Okay, so that is the max rate no matter what we do on our end. And it would just give us some flexibility, I think, to have some additional hours at a lower cost and you know, hopefully be able to really proactively stay on top of the communications specifically.
Any discussion on this service agreement? I just would like to add that with the amount of follow-up and follow-through that is needed on even the environmental scan, all the calls that had to be made back to the providers and you know, the stakeholders in general to make sure that they completed and they had their questions answered. It's very, very time consuming. Our projects have been up to this point in time. The expertise I think this paid intern support could offer is amazing at $12 an hour. We would not be going over our budget. I think it's an opportunity we should jump at. That's my feeling, but want to hear from everybody else.
I think Jason has done a terrific job. And just even looking at this update is an example of the good work that he does. And I agree with you, Mary Ann, that to me looks like a terrific deal, that we can expand the manpower or person power or whatever, what is politically correct. We're gonna have more trained people to help us with this work within the community. I think that's terrific. So I think that overall, we are giving a really terrific deal to the community and to the county for the kind of administration that Jason has provided for the amount of money that we're paying. Amen.
Any other comments?
I agree wholeheartedly. And I once again want to thank Jason for all, you know, the hard work and even the impulse to proactively look ahead and see ways that we could leverage resources without increasing our budget. So I just appreciate that impulse. And that's the type of thinking as well as impulse that, you know, we just need throughout government. And I really just want to say thank you for that.
Well, if there is no further discussion, then I would ask for a motion for approval of this extended agreement with the changes recommended in that you've just reviewed. So I'll need a motion in a second.
So moved.
Dr. Copeland made the motion. Do we have a second?
I'll second.
Second.
Oh, go ahead.
Dr. Morris seconded. So if there's no further discussion, all those in favor, please say aye.
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 Any opposed, same sign. Okay, the service agreement and the intern added has been approved. We will now move down to the mission, vision, and values principles statements, which is also an action item.
Okay. A little bit more. Yeah, just keep going. It's a long document.
Okay.
Okay. So I will just note to you all the changes that were made based on feedback and then leave it open for discussion. The vision statement was changed to, and actually the mission statement, I apologize for not highlighting, were amended to include substance abuse services more explicitly, so there was no confusion about that. That was one of the feedback comments. The awareness value was reviewed by a member of the disability community from RAMP, who suggested we be more explicit about stating disability as a categorization there, along with race, gender, economic class, and circumstance, that would speak to the disability community. and make them feel like these statements are inclusive of the disability community. And then, of course, substance use was added to mental health in that particular instance as well. Diversity, I know, Wendy, one of your comments were that the diversity statement was a little weak. I added cultural humility to listening. I think that cultural competence has been a core part of mental health services in general. I think cultural humility pushes that a little bit further and says that it's not an endpoint, but it's an ongoing life learning process of being open to learning and pushing yourself to understand that you will never be an expert about somebody else's culture, but you must always be learning from them. So I hope that captures.
I love that, what that, all the implications of that. Because, you know, when you're a member of a majority community, you approach culture as if you're the norm and everyone else is playing catch up, where cultural humility is more leveling the playing field. Everybody gets a voice. I like that. I don't know how anyone else feels, but.
Any other comments about that before we scroll down a little bit further? Okay. You know, I will comment that, I don't want to call anybody out, but I will. Dick kind of questioned the use of the word intersectional. Dick, I don't know if you had any feedback on that. It is kind of a word, can you scroll up a little bit, Kristen? Intersectional is a word that is probably maybe a trendier, newer word in some of the, you know, I think certainly in the collective impact world. So I don't know if people feel, is that too abstract to be meaningful, or is that
No,
meaningful?
I love that because,
Okay.
I mean, that's my opinion. I relate to that. And I think exactly what it says is.
I agree with Marianne. That
Okay.
it's very important.
Our friends from the disability community suggested that we might add a statement that is more explicit about accessibility. I think even as we were having a discussion today about our communications, we're maybe seeing the need for that we need to be a little bit more explicit about how we try to not just engage, but make our work product accessible to the entire community. And so
Yes.
This statement, I will just read it. We believe mental health and substance abuse services should be accessible for all people, irrespective of race, religion, gender, language, sexual orientation, and disability. So we promote ADA compliance, language access, and effective communication in all areas of service delivery.
Excellent.
Well done.
How about add age?
Age, yes, thank you.
I agree.
And as Marianne mentioned, as we get more into the environmental scan, I think accessibility really comes out as a critical issue in our community. Okay, so we can add age to that. The principal statements, equity was the only statement which had any real serious feedback about, and the one comment was with, I think Linda, you brought this up, that we originally had, we measure results with equity in mind, but we didn't talk about how we fund. So that was changed to say we fund and measure with equity in mind. And again, our friends from the disability community kind of also said that would be another nice place if you could be more explicit about disability as well.
And I was just looking at that. Should we, under equity, do we need to say social orientation also? Analyzing needs and outcomes by racial, ethnic, geographic, gender, disability, or other demographic. And maybe I don't know. I was just looking at the whole thing, trying to make sure that we had included sexual orientation enough.
I think that's a good point because it doesn't really talk much about it in here. And that's a huge.
So maybe I could go back and make sure that each of those ones that calls out the different demographics is inclusive of all the ones that and that it's consistent.
Yes.
So I appreciate you recognizing that. I don't think it's been consistent all the way through. So we'll make sure all of those include sexual orientation and all of those include age along with the other specific demographics categories that have been mentioned.
Excellent.
So I'll leave it. That's it. Those are the only. Danielle, did you want to maybe make a comment about the lived experience feedback?
I was hoping to get more than I got, so if we could be open to receiving more in the future. The only large comment I got, besides that it's not stigmatizing and it sounds like we know exactly what we're doing. Someone suggested that we draw out that like mental illness is a medical condition, but I think that what she meant by that is like to treat them as equals. I don't think, Jason and I had this conversation a little bit earlier and he had some concerns about saying it how she said it, but.
I think it's what, I don't want to speak for whoever made the comment. I think it's a good comment.
Right.
It really, in my opinion, relates more to parity.
Yeah,
making sure that health, that mental health is considered part of the health problem, not.
Yes, and that's what I also assumed she meant because I know who it is. I mean, that's how she said it, so.
And I appreciate that. I don't know.
So where would we put that?
Yeah, I think that just would have to be an overriding principle rather than, one specific point.
Wellness, under wellness. So you could say, we believe people need more than medication and counseling to be well. And recognizing mental illness and addiction issues are medical.
Well,
I don't know.
We could even use the word parity. I mean, to me, that gets right down to, because we do believe in parity. I mean, at least I shouldn't speak for everybody. We want mental illness and substance abuse treated like you would treat a medical surgical problem or health concern. So that is the definition of parity. And I would hope somehow we could communicate that is a principle, that parity drives our values and parity is a driver. It's not the only one. I don't know.
I also think it's important that we use holistic thoughts. Like you have to treat the whole person. It's not just about treating one condition. I mean, it will affect the rest of you, right?
Right. I would agree with that statement that the angle that we come from is important, in that the angle, I don't know that we want to, in my opinion, that we want to lay out a value that speaks just to illness as opposed to wholeness. In that the issues that we're concerned about are just as important, if not more important, than the things that are normally talked about for a person's wholeness, well-being, human flourishing, however you want to put it. I think we want to talk about the end goal. We want everybody to be. That why mental health is so important is because it's part of a larger picture of human flourishing. And this, to your point of parity, is as important, if not more important, than some of the other things that we prioritize. But I think—
Well, Pastor, I think you just said it. I think you just said it. Under wellness, that we believe that mental wellness is part of a system that supports the flourishing of the entire individual. And I've lost some of your words, but you said it. I think you hit it.
You know, can we make this simpler? Because I think that whole idea of wholeness is exactly what we want to get at. So under wellness, instead of saying we believe people need more than medication and counseling to be whole, is what I would replace well with. And we're at that time emphasizing the community support system. And if we look at the wheel around, the community support system, that is all the components to make a person whole. It isn't just mental health treatment. It is healthcare. It is housing. It is case management. It is, so to me, if we, rather than to be well, to be whole, I don't know. I mean, if
Also, we believe that mental wellness requires a community support system that relies on the multidisciplinary approach and parity across a continuum of care. Something, I don't know.
Jason,
Use the wordsmith.
Yeah, I have an outsider's question because all of you are much more versed in this than I am. Do we use the word healthy though, or do we not use it because we're talking about mental health? Because I'm just wondering if people can agree on what it means to be healthy as opposed to what it means to be quote unquote well or whole.
Yeah.
But you guys are the experts, so I'm just throwing that out there.
Well, getting, that what Reverend Copeland brought up, and that is we're getting into that issue between people who are suffering from serious mental illness and addiction, which is really where we started with this whole thing by saying, our definition of who is our target population. We said those people who are non-functional, those people who could not fulfill their ordinary social roles as the result of being impacted by either mental illness or addiction. And so I think we have to be, the notion of how we treat that, and that goes to Marianne's point, the CSP is an array of services that people need in order to be functional, to have social roles within community where they are able to be part of the overall community. And so I think we have to be careful that if we take it to a notion of health, and flourishing of, we're getting into then prevention, and we're getting into, an area of, I'm old, so I'm, we're talking about primary prevention as versus tertiary prevention, which is like where we really need to pay attention is to those who are casualties in this, who are in jail, who are in detention. That's where we're starting, okay? So, and the reason I say that is because I've seen mission drift with boards who get into this fight over, well, I really want prevention. Well, we don't have enough money or time that we can make the whole community healthy. So I mean, I just want to, kind of bring us back to where we started with this whole thing when we even had the discussions of like, why do we want public money to fund this issue? And the issue, and we wanted public funding is because there's an abysmal amount of public money being brought forth to help people who are caught in this that do not have insurance or other ways of getting help.
Okay, so in order, in concern for time, Dick, I agree with everything you just said. So I'm asking you, are you saying to leave wellness as we see it written, or are you proposing other changes?
No, I think that somehow we should, that wellness piece does need, kind of, we can bolster that by taking it to what do we mean by having this array of services under community support, and that is to bring people to a functional level within our community. And so that to me is what at least wellness would be defined as, is with the view that we have.
Could we say then with a goal of mental wellness, we believe people need more than medication and counseling to flourish. So we promote parity along with a multidisciplinary approach across a continuum of care.
Well, or we can go the other way around, Wendy, and that is to say, we support the community support system because it focuses on providing an array of services that bring people from illness to health.
That's simple.
I mean, because that is what we're talking about.
Right. I would agree with that. Any other concerns, questions? So, Jason? Is Jason there?
I'm writing.
Oh, you're writing.
Use my
I'm
phone.
so hoping you were writing what Dick just said. So you could kind of feed that back to us.
I lost it. I'm sorry. We have the video recording. Maybe I can go back and watch this conversation and try to find a cohesive statement that captures the essence. And I don't want to lose in that the lived experience voice that wanted to capture the essence of parity in that as well. So I think, shall we table this until next month or approve and amend? I mean,
Let's approve and amend.
I agree. Because this is important that we
Move forward.
yeah. So if there is any more discussion, hearing none, I'm asking for a motion to approve our mission, what is it? Mission, vision, and value and principle statements with wellness, the category of wellness, actually being rewritten as proposed by board members. So we can amend this at next meeting once we Jason goes back and listens to them.
So I move for approval of this document.
Do we have a second? Wendy, did you just do the second, or is your hand up, or?
No, I can't second.
I seconded it. It's Linda. I seconded it.
I'm glad. Thank you, Linda. Okay, now that we have the second, any further discussion? Hearing none, all those in favor, please say aye.
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 Any opposed, same sign. Okay, we have approved the mission, vision, values, and principles statement with the possibility, knowing that we will amend the wellness definition. Okay, moving on. We just wanted to discuss our purchasing procedure. And Jason, I think you're best to describe the discussion we had this week about it and what's been recommended by our treasurer, Ed. So maybe Ed wants to discuss it, or it's up to you, Ed, if you.
Copeland, go ahead, or do you want me to? So essentially, there's some purchases that, some items we needed immediately to execute some action items in the work plan. And since the mental health board does not currently have a credit card, I offered that we, Region 1 Planning Council, could make some of these smaller purchases and then include that in the monthly invoice that we make to the mental health board. So I discussed that with Marianne and Reverend Copeland, and I believe for now that was the accepted procedure until we can, I guess, until you guys can potentially decide to do anything more than that.
So I recommended that, Jason made that suggestion. I recommended that he do that for two reasons. I wanted, first of all, for us to get through the election and whatever happens, you know, with the board, the Winnebago County Board, with all of that. And then secondly, to give us time, I've asked Bill Gorski to help me put together some basically policies and procedures as it relates to purchasing that we can bring to the board and have some consensus on. So just to keep it simple, as simple as possible for right now, I felt it would be best just to follow what the financial committee of the county board suggested with their timeline as it relates to submitting requests for reimbursement and all that kind of stuff. And then here before the end of the year, once we see how the county board shakes out and if there's any changes there, and with us putting together our own sort of policies and procedures, we'll be in good shape. But right now, just let's keep it simple.
And Ed, your understanding, or at least it's my understanding, that no purchase would be made that would be outside our budget constraints. I mean, we would never be purchasing items that we have not budgeted for, put it that way.
Correct. Correct.
So in the small amount, we had voted on a YouTube channel, and the amount is small. So, you know, Jason wanted to go ahead and do that because we want to make sure that our meetings are live to the public. And then we needed Adobe for certain usages, and that also it's just a monthly fee. So those were really not significant purchases. So yeah, okay. So there's no action item needed on that. Also, liability insurance. I wanted to make sure that we kept this as an agenda item until we resolve it for us as board members. And Jason and I were able to fill out the questionnaire for the insurance company in order for them to give us a bid. So unless, Jason, you heard since we last talked from the insurance.
They asked me for a copy of the budget on Monday, and I sent that to them. That then triggered for them to send it to the underwriter. So maybe by the end of next week to receive a quote, hopefully.
Okay, so we will keep you apprised, and it will be on our meeting agenda for sure until we do resolve it. It's important to each one of us. So moving on down to the environmental scan results. And
we'll do another screen share for this, and I'm going to just combine the environmental scan results with the county board presentation because really they've turned into one and the same. Yeah, that one and then the other tab that's in it. So I don't know why that C is highlighted weird, but I'm gonna get rid of that. That's not intentional. So just the first thing is, as we're going through each one of these things, it always becomes like kind of a lot of questions for something simple, like what kind of slides do we want to use? Because really we've never made a presentation before, right? So we have a logo that was created through just like a logo generator that was kind of used on the web page as a temporary hold. I know we did budget money for a logo, so if we want to develop a logo through a professional company or something, we could do that moving forward. But the color green is the mental health awareness color, so that's why green is being used here. The color blue is the color for suicide awareness. So, so you've got those two colors, and then orange, you'll only see orange just on this first slide, and really that's just a color that represents bringing awareness to something in general. Is kind of like you wear it when you go hunting or something, like, hey, see me, don't forget where I'm at. So that's the meaning behind the colors. Certainly open to feedback about colors and format. So as we go through, the presentation to the Mental Health Board, Mary Ann will start us off, and she has, we've kind of pointed out some highlights of key moments along the way since March, since the inaugural board meeting, things that have been happening each month to show what the board has been up to. And then so appointment of the at-large board members, election of officers, bylaws adopted, the initial approval of the environmental scan framework and questions, and all the work that went into developing that. Scrolling down then in August, when the service agreement started with Region 1 and I came on board, the environmental scan survey was developed electronically and administered. There was a web page developed, two really, one on the county site and then one on the Region 1 Planning Council site for storing the meeting minutes and such. And then in September, the budget being approved and the work plan being approved for the following year. And then here in October now, compiling these environmental scan results. I mean, certainly I know there was a lot more work that went into each of those months, but I think those were probably some of the key highlights of actual work product. I guess before we go into the more detailed part of environmental scan results, is there anything else that anyone feels should be highlighted as we present to the county board?
I would add the adoption of the mission and vision.
Yeah,
in
well, we
October.
didn't have that till right now.
Right, till now, but I'd add that.
Mm-hmm.
Okay, for October, that's great. Okay. Okay, if we go down a little bit further, Dick, I don't know if you want to take a practice run at this right now, but or not. Dick will highlight the use of the community support system as a general framework to guide our work more broadly, and also to guide our environmental scan. Next slide. The environmental scan ended up with 123 organizations total that we were able to make some contact with. Some organizations that we tried to send it out to, the contact information we had for them was no longer valid, and upon phone calls and emails, we're just not able to get updated contact information. Some organizations are completely shut down right now due to COVID and not operating. So there was an inability to make contact, but for all intent and purposes, I believe we made contact with 123 organizations. 44 completed the survey in totality. 8 had a partial completion, and 2 agencies did respond, but responded in saying that they have new services that are not yet being implemented, so that they will complete it in the future when those new services are available. So in total, our overall response rate was 44%. Our completion rate was, of those who responded, 80% completed the survey, which gave us an overall completion rate of over 1/3. So about 36% of everyone who was reached actually completed the survey totally. And that is considered a good completion rate for surveys. Over 1/3 is generally considered a good completion rate. So I think we did pretty good, and especially considering the unique times that we're in, I think it turned out pretty well. So looking at some of the actual results in the treatment service delivery area, there's actually 4 components to that. So looking first at diagnostic evaluation, which is defined as essentially making those initial assessments and ongoing assessments to get the accurate diagnosis and connect to proper services. There's a total of about 30 agencies that provide this service. So think about that in the context of the 44 that completed the survey. 25% noted to have a waiting list. 50% said that they offer same-day assessments. The day the person comes in, they get assessed. Overall payment accepted included roughly just under 50% accept Medicaid. A smaller percentage accept Medicare. That tended to be a theme throughout, one that surprised me because Medicare is traditionally thought of as a more secure payment method because of the federal government generally is, is seen as reliable for paying their bill. So it's surprising to me that Medicare was generally in almost every service area less accepted than Medicaid. And so as we're talking about target populations and accessibility, we really have to think of the elderly population when we think of the array of services and what access they have when their primary insurance is Medicare.
Jason, I just want to comment on that. The reason that it is lower than Medicaid, Medicaid pays for all sorts of credentialed people, even bachelor level. Medicare, you have to be a licensed clinical social worker and you have to apply for a Medicare provider specialty. And that takes a lot of time, and it's up to the individual clinician to do that. So if you're working for an agency, a lot of licensed clinical social workers maybe don't want to go that route. So that's why it's more, it really is more specialized for the mental health services, just so you know that.
Thanks, Marianne. That's really good context for that. And I think that helps us understand what some of the maybe root causes are of that particular gap and how we might look to address that.
Right.
Private insurance, generally, not always, but generally is accepted at a much higher rate than Medicaid and Medicare. There's a little nuance to this because some of Medicaid and Medicare is managed care. So sometimes when somebody signs up for Medicaid or Medicare and they get a Medicare Advantage plan, they end up looking to a provider like they have private insurance because they're coming in with a managed care policy. So that might be one where a little bit more conversation needs to happen to understand when people said private insurance. I assume most of them were probably including any type of managed care.
Absolutely.
About 2/3 serve uninsured and about just under 2/3 provide low cost or sliding scale. Not a huge discrepancy here. In other areas, there's a much larger discrepancy. Interpretation services across almost every area of service delivery was just unacceptably low. 25%, 25% of service providers that actually are able to provide an interpreter, and 33% are basically saying no interpretation, even knowing that one of the options is that the person could provide their own interpreter, right? So that's saying, even if you have your own interpreter, we can't do the translation service. And sometimes that gap can exist because it might be an agency's policy or even their funding source's policy that the interpreter has to be certified and registered, so that they know that there's no type of editing that's happening by the interpreter to change what that person is saying. So there's some red tape around that, but it certainly creates a gap, and you'll see it almost across every service area. If we move on to supportive counseling, we see some similar trends here. 28 agencies, 25% waiting list. Focus areas certainly show, and across the board, this generally was true, that mental health was more, there were more service providers that did mental health than substance abuse. So you'll see, there's 58% that do just mental health and 41% that do mental health and substance abuse. So really only 41% of those agencies are providing any type of substance abuse counseling. Payment models here, similar to the last one. Medicaid kind of in the middle, Medicare the lowest, private insurance the highest. See a little bit more of a discrepancy here between where a lot of people saying we'll serve uninsured, but not as many saying we provide low cost. So the implication there is that, yeah, we'll take you if you're willing to pay full price cash, basically, which is probably not the reality that most uninsured people are facing, that they're able to do that. This was a highlight in a really great way. The trauma-informed numbers are super high. Only 7% of the agencies said they do not provide trauma-informed, and 76% said not only are we trauma-informed, but we also have trauma-specific counseling. So that's impressive, and I think that shows how this community has really owned trauma-informed and being trauma-informed, and how that has impacted our service delivery system. Medication management, we're talking about not just the prescription of medication, but also in some cases helping, like a different type of clinician helping a person manage their medication. Okay, so much less agencies in this area, only 11. And we'll see the discrepancy here ends up being that there's many more services available for adults than children. And that tended to be generally true as well. Medicaid, much higher percentage here, almost equivalent with private insurance, but then that big discrepancy again between those who will serve uninsured and those who are actually willing to do low cost or sliding scale. Interpretation, again, a little bit higher here at 46% that will provide an interpreter, but when you're looking at such a smaller number of agencies, that percentage really records the number of options. You're looking at maybe 5 options for an individual that needs interpretation service provided. Substance abuse services, as mentioned, were generally less available than mental health services more broadly. As you see here, only 8 agencies saying that they provide detoxification and other types of alcohol and drug specific interventions. And look at the waiting list number. From 25% with some of the mental health services, here we're seeing 37.5% and much less mobile. So more in office and less in the community. Medicaid number way lower than almost any aspect of mental health specific services, and the low cost options are pretty low there as well. In terms of actual detox, that 12.5%, that's one agency out of 8. And residential services at 25%, that's 2 agencies. Recovery home, 25%, that's 2 agencies. So there are not a lot of options for someone that needs pretty intensive substance abuse treatment and intervention. Other community data that was taken to help contextualize some of this includes the Children's Mental Health System of Care Key Informant Survey and a survey from the Winnebago County. It was the Mental Health Committee that was working, that did that survey back in 2016. That was an actual resident survey, so it got the resident perspective, whereas these other 2 surveys got more of the provider perspective. And across the board, the commonalities you'll see, the well, really all 5 of those are related to lack of availability of child psychiatrists, particularly those that take Medicaid. And we hear that across the board. Anecdotally hear that all the time, and I think the survey data tends to support that that's a big gap. Crisis response. I highlighted 2 out of the 4 crisis response areas. The crisis telephone services were actually surprisingly probably more robust than I would have expected, with like 12 agencies providing that service on a 24-hour, 7-day-a-week basis. But the crisis outreach services, I think, show some gaps in service. Although it's great, we have 10 agencies, serve about 165 individuals a day. We see again here, low Medicaid numbers, but also low private insurance numbers. And I do wonder how many of those services are fee-for-service versus some type of other funding source. That might be a good follow-up question for some of these agencies. And looking at the locations, some good coverage, schools, county jail, really low with primary care clinics. And that's one of the areas you want to see stronger integration of mental health services. So I think that's a gap and kind of an area for really more questions. Why are crisis outreach services not reaching primary care clinics where there should be a total integration of those services? Hospitals also, why are hospitals lower than the jail for crisis outreach services? Place of employment, that should be 40%, not 405. I was happy to see that place of employment is being reached. And just in the other comments made were the police station and the juvenile assessment center. Interestingly here, 50%, stay on that last slide for a second, 50% said they do work with law enforcement and jail diversion programs. 90%, so 9 out of 10 said, no, we do not believe that the law enforcement are adequately trained to work with mentally ill or addicted. Crisis residential, only 4 agencies. Crisis residential is basically somebody staying inpatient in a residential setting. So it's like a hospital experience in a residential setting, and it can sometimes be a stopgap to keep someone from needing to be hospitalized in a more restricted environment. So
there are 4 agencies that provide that. I know of 1.
Yeah, I guess I would say that probably Stepping Stones might provide some form of that, although it's probably to their own clients and not clients outside of their services. But I think they have rooms or beds within their facilities that can be used for crisis. I think the other 2, I need to go back and look, because I agree. I thought there might only be 1 or 2, and so 4 was actually surprisingly high there. I understand those to be Medicaid and Medicare. I wasn't aware that private insurance was an option for those. Marianne, do you know if that's an option at Rosecrans?
Well, I mean, it depends on the insurance company. We have gotten private insurance to pay for that. It's
Okay.
a conversion from the hospital. It's much lower rate, and it's, you know, keeping this person stable and out of an institution. So,
And you also might want to break that out by age. So are there agencies that work with kids?
no, there are no crisis residential for kids. I can
Okay.
tell you that. Unless it's like a milestone that has it within house. But in terms of a community crisis residential, I've never heard of one unless one has been developed. Linda might know, you know, through her United Way.
Well, I believe that this one did show that there were, I think, maybe 2 or 3 agencies that did provide this service for children. So there could have been a misunderstanding of the service area, but I will look at the agency.
Well, Jason, what I'm thinking is somebody like Chazzy may have a crisis response for their kids who are in foster care, for example.
Yeah, that could be in Children's Home and Aid.
Right, or the acronym escapes me, but like through YSN or do they still have a SAS team for kids who are?
Team is at Rosecrans.
Oh, okay, all right. So I don't know, that it's been a while, but.
Yeah, we can unpack this one. And since there's only 4 agencies, if there's somebody we have a real question about, that we can do a follow-up conversation to find out what that is. And I'll try to get some clarification before the county board meeting.
Good.
So that we're not unaware of what that is. 25% providing interpretation when there's only 4 agencies is pretty troubling. That really doesn't provide a wide array of options. And only 50%, well, 50% said, I guess, depending on what type of physical disability, they might not be able to provide that service. So it would be worth, I think, some more conversations on this as well to find out if these facilities that exist, what physical disabilities are not able to be accommodated and why. Okay, and so there's just one last area here, which was case management. And, you know, case management is important because it goes through, connects all those other areas. And so here again, we see some discrepancies between, well, there's not a discrepancy between Medicaid and private insurance. It's just that both are really low. So, and then a higher number that provide uninsured. Interestingly, 19 agencies felt that they provided this service, you know, based on that definition, even though not a lot of them are accepting, all of them are accepting some type of fee for service for it. It seems based on what's accepted for payment model. And interpretation, a little bit higher here at 50%, but still not probably what we'd like to see as a benchmark. A little bit of other community data contextualizes this. You know, resident and provider response and agreement that people are not all aware of what resources are available, and that service providers themselves don't all know what other services are available. And then, of course, what we've noticed from our data, that services need to be more accessible for English proficiency, immigrants, and people with disabilities. So that would be then lead into giving an update to show our fiscal year work plan that was approved and our next steps and how we're going to take this data, identify strategic issues, do some public participation to prioritize the issues, develop a 3-year strategic plan, and then develop RFPs for specific focus areas that we want to see improvement. And that's it. Thank you. Any questions?
I think it's well done. Well done.
What a great job.
Oh, yeah.
Jason, well thought out. That was really good. Really good.
I do have a comment. I think that the CRC is going to start working on mental health as part of, you know, what's going on in our community. And I may have to ask you to come make a presentation, a quick one, to kind of let us know what's going on there. That's probably going to be in November or December.
Okay, thanks for letting us know. I think, yeah, I hadn't thought about this as part of our communications plan because we put it together so quickly, but maybe being strategic about some presentations. I know, Mary Ann, you have an opportunity to present to Nami, correct?
NAMI is having the mental health rally virtually on Friday, and I was asked to update the attendees as to the progress of the mental health board. So I'm going to share, the timeline, and highlight the accomplishments up to date. So, yeah, I'm going to use that.
And Marianne, and one of the things that Jason and I have talked about is it's important that each of us be able to speak independently, but all of us be aware that what we're communicating is exactly what you just said, that we're all communicating what the plan of work is and not, get ahead of ourselves,
Exactly.
So, and I think that's important. So.
I so agree. Well, any other comments or questions about the environmental scan and what, Jason presenting this to us today, I see more questions than when I reviewed it privately. So I'm thinking, this is, it kind of just pinpoints areas that automatically need focus because of either, the people on able to pay for the service or not enough of the service being available. So I think that's going to help us with our RFPs and in our focus areas. So this has been great. And Dick Hooner, might go back to your spearheading this environmental scan, and it was awesome. And you did such a fantastic job, and the results are really telling, and it's going to really help us make some good decisions. So thank you for all your time in that.
I'm seeing some comments in the chat. I did get those. I will double check those. Thank you for the editorial comments. I'll make sure those are corrected in the presentation as well. Marianne, so, that I think was the last item on the agenda.
Other matters.
Yeah, sorry. I was going to say, because we have like a press release too now. I don't know if you want to read that at the end of the meeting for comments.
Sure.
As well.
Right. So the mental health board knows exactly what's going out in the press release. So Jason and I talked over this today. And so Jason, you put it together. I'll let you read it.
Okay, so we'll just quickly do a screen share and I'll, read that. And if we just do this at the end of each board meeting, then we can have more proactive communication. The Winnebago County Community Mental Health Board held a scheduled board meeting today in which they approved mission, vision, values, and principle statements. I'm glad we did that. These statements were developed over the course of the past several months with great reflection and consideration and will guide the work of the Mental Health Board. Feedback was provided from individuals and family members who have experienced mental illness and/or substance abuse disorders directly. The statement can be viewed on the board's webpage, and then that links to the Winnebago County webpage with the Mental Health Board's link. The board also reviewed some key findings from the environmental scan survey, which was conducted August through September 2020 to assess the array of mental health and substance abuse services offered in Winnebago County. These findings will inform the development of a 3-year strategic plan aimed at improving the mental health and substance abuse service delivery system. The plan will guide the prioritization of funding for services and programs. The Mental Health Board will be presenting these findings along with their fiscal year work plan to the Winnebago County Board on Thursday, October 8th, 2020. This is a quote from Marianne. The data really helps us pinpoint our focus. It's helpful that we can identify where there is duplication of service and where there are gaps, says Board President Marianne Abadi. We can now help those individuals who have limited access to services and remove the barriers that keep them from receiving these much needed services.
Okay. So we don't.
Well written. I
Go
agree.
Good. Good. And hopefully, as Jason talked about in the beginning, is that, you know, not just myself, but other board members will be able to give a quote, you know, for this kind of press release. So, and after we get so well known, you know, with our PSAs, and, you know, community will be waiting with bated breath for our wisdom. So anyhow, other matters, I have none. Any discussion, any comments?
I move for adjournment.
Very good. Dick's always good at doing that, and I like that.
You're my guy, Dick.
Yes.
Give us, what's the date of our next meeting?
Do you
Oh,
have?
sorry. Yeah. Are you asking?
November 4th.
November 4th? Okay,
Thank you.
thank you.
Okay.
Okay.
Okay, we need a second
A second.
for the adjournment motion. Danielle, did you say second?
No, yeah.
Okay, so all those that are in favor say aye.
Aye.
Hi.
Opposed?
Bye all.
Thank you, everyone.
It's been good being with you.
Yeah.
Nice
so
job.
Take care.
Thank you for all the hard work.
A
Stay
lot.
healthy. Stay healthy, everybody.
Yes.
You do the same. All righty. See you next time.
Bye.
Next time.
Bye.
Bye-bye.